Remember a couple slides ago when we talked about the uterus being comprised of 3 sections? Well, to continue with that rule of threes, the uterus is also 3 distinct layers of tissue. The 3 layers of the uterus are the perimetrium, the myometrium, and the endometrium. The endometrium is the innermost layer, which changes under hormonal influence and pregnancy. It's the layer that the egg is supposed to implant itself into. It is the layer that is responsible for endometriosis, should that layer of tissue be found outside the uterus in the abdominal cavity. The myometrium is the layer that is responsible for uterine contractions. These take place obviously during labor and childbirth, but they also occur throughout the life of a female even when not pregnant. Cramps during normal monthly menses and cramps immediately post-childbirth occur to expel contents of the uterus out. As a surgical technologist, you may be involved in a delivery. It might be vaginal or cesarean, regardless, but you may be called upon to massage the uterus to aid in post-delivery contractions, and this helps the uterus resume its normal size and location in the pelvis, and it helps expel remaining amniotic fluid and blood. And so this step actually intimidated the heck out of me when I was pretty new. And so I just want to make sure you know that you have the right to ask questions and you can ask for guidance from your preceptor on how to massage the uterus post-delivery. So don't ever let your nervousness or insecurities compromise your patient. And finally, the perimetrium is the external most layer that is continuous with the peritoneal fold we talked about previously that creates the bladder flap. The perimetrium and the pelvic peritoneum are typically the most likely locations the surgical team may discover endometriosis during diagnostic procedures. Remember, endometrium should be on the inside, and so endometriosis indicates a pathological condition in which the inside tissues of the uterus are outside the uterus. And this can cause intense pain for the patient and is treated in a variety of ways, both medicinally and surgically. Okay, so we've covered the almighty uterus anatomy, and now it's time to talk about other pelvic anatomy that is also important for function. So first we're going to talk about the fallopian tubes. The fallopian tubes pass the ovum, which is the medical term for egg, from the ovaries into the uterus. This is a very important detail because it is the ligation of the fallopian tubes during tubal ligations that provide elective sterility to the female patient, otherwise known as getting your tubes tied. The fallopian tubes are 4 distinct sections known as the interstitial, the isthmus, the ampulla, and the infundibulum. I love to say infundibulum. The interstitial section is the part that actually connects to the uterus at the fundus. The isthmus and ampulla are the tube itself. The isthmus is narrow and the ampulla is wider. The infundibulum is the terminal end of the tube with fimbri attached to it. Fimbri are little projections off the infundibulum that swell with blood during ovulation, and when they're swollen, they are larger and can sweep across the ovary to collect the released egg and send it along the fallopian tube. Kind of reminds me of coral in a reef swaying back and forth. The fallopian tube is not connected to the ovary, but it is instead suspended to the abdominopelvic wall by the infundibular pelvic ligament. The inferior portion of the fallopian tube is suspended by the mesosalpinx. This too must be divided during surgery on the fallopian tube. The medical term for fallopian tube is salpingo, and another important fact about the fallopian tube is that it is not designed to house a developing fetus. Occasionally, a fertilized ovum will implant itself into the fallopian tube, which can actually be fatal to the mother. The ovum, in this instance, will continue to grow and develop, and eventually it will rupture the fallopian tube and cause life-threatening hemorrhaging. And this has to be remedied by an emergency procedure called the removal of ectopic pregnancy. And unfortunately, there is absolutely no way to implant the fertilized ovum deeper into the uterus. And so in these instances, neither the fertilized ovum will survive nor the mother if things don't get fixed. So this can be a really challenging procedure for patients, especially if they're trying to get pregnant and then they find that not only did they get pregnant, but now it might kill them. It can just be a really tough surgery. So you might have a exceptionally emotional patient and or family on your hands if you have to do a removal of ectopic pregnancy in your practice. Okay, so next are the ovaries. They are the female sex gland. They are responsible for producing female hormones. They house about 1 million eggs each, which females are born with. It's crazy, but eggs are not produced after birth in a female. Baby girls are born with them. And so the ovaries are suspended by a peritoneal structure called the mesovarium. Oh, hey, look, fimbriae. All right. Mesovarium, there it is. And they are attached to the uterus. Okay? So fallopian tubes are not attached to the ovary, but ovaries are attached to the uterus. Okay? All right. The reason it's important to know where these structures are attached is based on the procedures that patients are going to be scheduled for. Okay? So seems like we had better know our medical prefixes for this specialty. That way we know what kinds of procedures are going to get scheduled. So I need you to know the layman translation for hister, and I need you to know the layman translation for salpingo, and I need you to know the layman translation for UFO. And did you notice that I was so nice that I gave them to you in order just now? Repeat after me. Thanks, Jen. You're super awesome. You're welcome. Okay, so now that you know that the uterus has fallopian tubes and ovaries and you know how they're all attached, do you think that we can remove just the uterus? What about just a fallopian tube? How about a combination of any of the above? What if the patient is scheduled for an abdominal hysterectomy with bilateral salpingectomy? First of all, what the heck are we doing? Write it down on your notes in layman's terms. If you study and learn the anatomy, you'll know what to anticipate for your surgeon. So since you know the fallopian tube is attached to the pelvic wall by the infundibular pelvic ligament, you know they will want to ligate that first before they do anything with the uterus. And then you will be ready to pass a clamp, and then some scissors, and then a stitch before the surgeon even begins to take down the uterine ligaments. Another example is the laparoscopic oophorectomy. You know the ovary is attached to the uterus and not the pelvic wall, so the ovarian ligament and the mesovarium get divided from the uterus and removed from the patient. And finally, remember, tubes and ovaries are side-specific organs.